My name is Paul Bunn. I'm a professor of medical oncology at the University of Colorado here in Aurora, Colorado. Lung cancer remains the most common cause of cancer death in the United States and in the world. The majority of cases of lung cancer, including non-small cell and small cell, are caused by cigarette smoking, and that's even more common in small cell lung cancer. Small cell represents about 15% of all lung cancers. As opposed to non-small cell, small cell tends to get into the blood sooner, and therefore more patients have extensive stage or stage 4 disease at the time of presentation. So about 3/4 of patients with small cell lung cancer will have extensive stage at the time of diagnosis. Because the cells got into the blood and spread somewhere else, we need a systemic treatment that will treat them by going into the blood. And for many decades, that has been chemotherapy. And over the last 2 or 3 decades, that chemotherapy has been etoposide with cisplatin or carboplatin. Unfortunately, while that produces a very high response rate, about 90%, patients are not cured. The most recent exciting thing to happen in the treatment of extensive stage small cell lung cancer has been immunotherapy. And 2 immunotherapy drugs, atezolizumab and durvalumab, have been shown to improve survival when added to chemotherapy with patients with extensive stage small cell lung cancer. Now, the magnitude of that difference is perhaps not quite as great as it is in non-small cell lung cancer. So the median survival of people with extensive stage treated with chemotherapy is around 10 months. And that goes up to about 12 and a half months in people that get chemotherapy plus durvalumab or atezolizumab. That is important, but what's more important is now that these trials that added the immunotherapy to the chemotherapy have long-term follow-up, there is a fraction of those patients who remain alive without treatment at 5 years. So in the 2 trials with immunotherapy and chemotherapy, about 20% of the people are alive at 5 years. And so that's a major advance, where there used to be essentially 1 or 2% of people that would be alive at 5 years. Unfortunately, we don't know how to predict who those patients are that are going to have the most benefit. So right now we treat everybody. But in addition to finding more immunotherapy approaches that will improve outcome further, we have to find biomarkers that are going to tell us which patients benefit the most from the addition of immunotherapy.